Hi everyone, so welcome to our webinar for this evening. We've done a few of these now and they've been very successful, so we thought we would do an update today on modern management of vestibular schwannomas, and we'll be focusing on a few different areas, so surgery, radiosurgery, and also AI and some of the new research that we're doing. We've got an excellent panel today. So the first talk is going to be Professor Saeed. He's a neurotologist. He has a very wide experience of vestibular schwannoma management. He has been chair and president of multiple different major otological societies and skull-based societies. And he's going to start us off by talking about the modern management of vestibular schwannoma.
Okay, thank you, Patrick. I hope you can all hear me and see me. So I'm going to talk about the management as we see it in the 21st century and how it's evolved, but also going to ask some questions about the decision making that we find ourselves having to undertake, and some issues around the investments that we have in that decision making. So just to give you context, my lateral skull base and neurotologic experience over the last 2.5 decades, longer actually, you can see that there's a wide range of neurotologic and skull-based pathologies that I deal with my neurosurgical colleagues in many instances. But by far the largest pathology that's been referred, the largest number in terms of the pathology that's been referred into me at UCL at Queen Square is our patients with a vestibular schwannoma. And just no disclosures to declare, but I would like to acknowledge the fact that I've worked with a cohort of excellent neurosurgeons over the years, firstly as a consultant in Manchester for over a decade, and then more recently my time in London, both at the Royal Free and UCLH, and at Guy St Thomas's and King's College Hospital, which is where I practice. So some of you may recognize this individual. This was the famous manager of Liverpool Football Club who transformed the club in the 1960s. And he was asked once by a reporter whether football was a matter of life and death. And his reply was that it was actually more serious than that. Well, of course, it isn't. But even in the 21st century, a large, uncontrolled, growing vestibular schwannoma could be a matter of life and death. Rarely is now, thankfully. It's very rare to see someone lose their life because of the pathology, or indeed, thankfully, because of the interventions to deal with it. But nevertheless, we mustn't lose sight of the fact that the nature of this pathology potentially can be very, very serious. And in terms of surgical mortality, this is now in experienced hands is less than 1%. You can see how it has evolved over the years from the days of Cushing, which a landmark time in terms of understanding the importance of the arachnoid plane and the tumor interface. And you can see that the mortality dropped significantly from what essentially was almost a universal mortality prior to the early part of the 20th century. And we've now evolved. The initial objectives of managing a patient with a vestibular schwannoma was to preserve life. And then once life was preserved, the preservation of limb, i.e. mobility and able to walk again, so to speak. And then preservation of the lower cranial nerves and the bulbar function itself. And then in recent decades, the preservation of facial function. And now, aside from tumor control, the aim is also, if possible, to try and preserve serviceable hearing in the individual. And if we look back to the beginning of the 21st century, this was a survey I did in the early 2000s, and it was published in 2006, so nearly 20 years ago now. You could see that a survey across the 4 busiest vestibular schwannoma services in the UK at that time showed that, without exception, irrespective of what their overall caseload was, the majority of these patients underwent surgery. But this is where the first paradigm shift occurred, and this was to consider serial imaging. And this coincided with the the availability of MR imaging to detect these tumours sooner, and then to look at the natural history before necessarily intervening surgically. And this is one of my most important slides. It shows that the evolution, or the number of patients that were referred in red and those that underwent surgery in blue, that there was a change in the 1990s such that the majority of patients ultimately would not undergo surgery, or a proportion that underwent surgery gradually diminished. And this was a slide from Richard Ramsden in Manchester, who was my mentor and trainer. And you can see in his professional lifetime, going up to the 2000s and beyond, you could see that not all patients who were referred ended up having surgery. So that was the first paradigm shift. And did the literature support this? Well, we published in Manchester many years ago now, and saying the Cambridge group as well, that showed that over a period of prolonged observation, 2/3 of these tumours did not necessarily grow. And so the decision to intervene from the outset was not necessarily the correct thing to do. So the literature has supported that. And the second paradigm shift was, in parallel, was the use of stereotactic radiotherapy or radiosurgery in various forms. And this is one of the seminal papers from the Mayo Clinic, which showed that even with reducing dose schedules, you could see that the preservation control of tumor growth was significant, with diminishing impact on trigeminal and facial function with the reduced doses. So the literature also supported this. If you look at the earlier literature that looked at the role of radiosurgery in these patients, you could see that the control rate was at least 90% and often 95%. And that's a substantial, had a substantial impact on how we manage these patients. And then the third paradigm shift was to go from the original objective when in patients who were undergoing surgery, which was to remove the tumor, to move away from that, to preserve facial function in particular. As you can see, this is right at the end of the operation. There's a little nubbin of tumor here, and a severely attenuated but normally functioning facial nerve. And there was a time when we would probably have tried to remove that, but now we would certainly leave that. And so we've moved to near total or even subtotal, planned subtotal in selected patients. And so the current algorithm that myself and my colleague work to at Queen Square, certainly the firm that I work on, is that if you have a small or intracanalicular tumor, we will tend to, irrespective of the hearing, we'll look at serial imaging. And if there's no growth, continue along that line. And that can be as many as 2/3 of patients that will continue in that vein. Medium-sized tumors, then it does depend on the hearing, the size of the tumor, and other patient factors as to whether we consider surgical intervention or stereotactic radiotherapy intervention. And for larger tumors, there is generally a consensus around the role of surgery. So what are the options then in the 21st century? Well, it depends on tumor size, it depends on your age, it depends on the hearing, critically in both ears, because hearing is a binaural brain perception, and the hearing in the opposite ear will have a significant bearing on the overall disability of the hearing impairment. And critically, it does depend on who is managing your care. And one of the aspects that has become very apparent to me in the decades that I've been working in this field is something called emotional investments that play a role in decision making. Now, this applies to surgical decision making, but actually applies to all healthcare interventional decision making. This was a really important paper that came from one of my ENT colleagues from Belfast many years ago that looked at emotional investment in surgical decision making in a disease called Meniere's disease. But the principles are the same, and that is that this can create problems for surgeons, and sometimes they have difficulty in recognizing that they need to change what they are doing and look at the evidence and question the appropriateness of the surgery if that is what they're advocating. And it's interesting that this was a USA-Norway collaboration published not long ago in 2018, which showed that when you look at the cohort that they looked at, which was a small and medium-sized tumors, over 500, that 27% underwent surgical intervention, almost half underwent stereotactic radiosurgery in one form or another, and a quarter were observed. And the overall factor that had an implication on the decision-making remember these are small and medium-sized tumors, was the recommendation of the physicians. So how you counsel your patients in terms of their options has a huge bearing on the decision that they will make. And that underpins the importance of a multidisciplinary team approach. So based on all of this, when I was the president of the British Skull Base Society many years ago, we proposed that there should be a national UK prospective audit. And we published this recommendation many years ago. And having instigated this, it was delivered by Patrick Axon in Cambridge during his tenure, and currently is chaired by James Tyson, also in Cambridge. And it has been open for data entry for over a decade. And there's a huge cohort of patients there, 18,000 plus, which is one of the largest databases or registries that exists. One of the issues, of course, is how you manage these intracanalicular and small tumors, because there is no equipoise depending on the department that is managing the patients, the country that the patient is in, and so on and so forth. So I interrogated the UK database, and it would seem that the small and intracanalicular tumors comprise almost 70% of the tumors, as you can see here, of that 17,000 patients. And you can see here that for small and intracanalicular tumors, the majority are under surveillance and did not need further intervention. And here you can see that the small tumors, 3/4 continued under surveillance. I did not need intervention. And for intracanalicular tumors, that's almost 9 out of 10. And that's based on a cohort of over 17,000 patients. And if we look at the Danish data, this is important data from Copenhagen, because almost every patient with a vestibular schwannoma in Denmark is managed in the same unit, and they've prospectively collected their data for a very long time, going back 40 years or more. And you can see that when we look at the 2/3 of these were observed over 2,300 patients. And again, for intrameatal, just 4 out of 5 did not show growth. And for extrameatal, for small tumors, you can see that only 1/3 actually showed growth. And these numbers do change at 10 years. And tumor growth usually declares itself within the first 5 years. What about the hearing itself? And again, if we go back to the UK database, now this is where there is a flaw in the database, in that the hearing data is not as complete as the overall tumor size and growth data. But even then, you can see that for small tumors, around 70% are preserving the hearing at diagnosis over the observation period, and a similar number for the intracanalicular tumors as well, those that are on continued surveillance. And this is reflected in the Danish group, that half of the patients will maintain Class A hearing. Over half, 60% almost, will maintain Class A hearing at 5 years. And if they presented with 100% speech discrimination, then almost 70% will maintain that at 10 years. So it would seem that based on substantial data sets, the best way to manage tumors that are not growing and to maintain hearing is to actually leave the tumor alone. What about hearing preservation surgery? Because this is another almost dichotomous situation, where these very types of patients are advocated to have surgery to try and preserve their hearing. And this was a collaboration between Italy and Spain. You can see that of the 92 patients that underwent surgery, half had serviceable hearing post-op. That means that half lost their hearing as a consequence of the surgery. And based on the data that I've already shown on a much larger cohort, then that would argue that this was probably not the way to go forward with these patients. And again, when you look at this publication that's come from the US, you can see that they had 164 patients with sporadic vestibular schwannoma, intracanalicular or small tumors that underwent surgery. 71 of 78 completed the post-operative quality of life questionnaire. So the question you've got to ask is, what about the other 70, 80 odd patients? What happened to them? And I do question how this actually got past the review process, if I'm honest. But they found hearing preservation in 48 of 71. Well, that's not dissimilar to conservative management, and arguably a little bit worse. And here's the critical thing for me. There are 7 patients of the cohort that actually responded that actually didn't have normal facial function. And so I would argue that those patients in particular have been done a disservice based on this decision making. So how do we minimize emotional and other investments in decision making? Well, I think rigorous national and international databases and registries are critical. They've got to be the interrogation of them has to be robust. There has to be buy-in to clinical practice guidelines. And I think every patient presenting with this type of problem should be assessed by a multidisciplinary team so that you do not invoke emotional or other investments in the decision-making process. And just finally, evidence-based medicine. Well, the problem is that most of the evidence in the field of vestibular schwannoma is a low level of evidence, level 3 at best. It's not poor evidence, but it's a low level. Whether you look at the Oxford Centre for Evidence-Based Measure, the US Preventative Services Task Force levels of evidence, and the critical thing here, a well-designed and well-inputted registry gives you a higher level of evidence. So I think that's critically important as well. And so when it comes to vestibular schwannoma management and the decision making, well, the face on the left, as I'm looking, and I suspect as you are looking, is what I call a very expensive face. You'd need to really get that decision to be robust if that was your patient. But these individuals who are ordinary members of the public are also very expensive faces as far as I'm concerned. These are my family and children and grandchildren, and the decision making should be absolutely the same process for decision making, irrespective of who the individual is. And I shall stop on that note.
Great, fantastic. Thanks a lot, Shak. So that's an excellent talk to start off with. And what we're going to do is at the end, we'll have a round of questions with everybody on the panel. So if you have questions, please put them in the comments and then we'll go through them at the end. So we'll move on to our next speaker, and that's going to be Matt Radatz from Sheffield. So Sheffield really have the widest experience going back many years of focused radiation, so gamma knife radiosurgery for vestibular schwannoma, and Matt's going to give us a summary of that data and experience.
Thank you, Patrick, for the introduction, and thank you for that excellent talk from Professor Shakeel. Stereotactic radiosurgery for acoustic neuroma. I have to summarize about 40 years of experience here in Sheffield with the gamma knife radiosurgical program, which was established in 1985 by David Foster. That's a prototype of the gamma knife installed at the time. It was a totally manual machine, and much has changed since those days. Not only on evidence base, but technology-wise and radiation delivery-wise as well. The only thing what has remained is a source we are using. It's a cobalt-60 source emitting gamma rays, which we are utilizing to focus down on in this particular scenario here, the acoustic neuroma. What are suitable targets for gamma knife radiosurgery? They need to be ideally sharply defined. They need to be visible. An acoustic neuroma is very well identified now with, in particular, MRI imaging of the highest quality, which we have, which is has changed materially over the last 40 years, and I will show you some evidence of that. Ideally, smaller lesions, the maximum acoustic neuroma size we would be usually taking on for treatment is below 3 centimeters in diameter. There are exceptions, and these are not for this talk, but usually are limited to patients who are not fit for having alternative treatment modalities, not fit for surgery or general anesthetic. But that management would be still doable, but with different parameters and in different circumstances. Principles are stereotactic imaging to define the stereotactic space to localize the tumor within the head in a submillimeter fashion. The dose planning, tight dose confirmation to the contour of this tumor to avoid eloquent structures, and in particular in the acoustic neuroma, they typically on the surface running facial nerve here. And then the dose delivery, which is with the benefit of the gamma knife, with very little moving parts, highly precise and conformal delivered. On the left, you can see what we were relying on in the early days. There's a contrast-enhanced CT scan, and you can see that the quality in comparison to the current imaging modality used, the MRI scan, was very different. So it is different. It's difficult to put all these patients into one pot because the modalities were different, the quality was different, the radiation delivery was different. It took longer to deliver the radiation than it would take now. So the radiation biological effect was different. But over the 40 years, we have gone through an evolution of gamma knife radiosurgery for acoustic neuroma. And what I can say is that it has massively improved and the outcomes are significantly better than they used to be in the early days. Here you can see just an example of an acoustic neuroma treated with gamma knife radiosurgery and with a 2-year follow-up imaging where you can see the central contrast uptake reduction as an indicator that the tumor is gradually demising. Now, from 1985, when we started out, the machine was developed or taken up into service to develop a program for AVM radiosurgery. But we did get acoustic neuroma referrals, and those patients in those days were treated. The dose delivery was different. We used higher doses because nobody in the world had done it before, and nobody knew what dose would be required to stop the tumor from growing or to shrink it. So the dose itself we prescribe has gone through an evolution over the decades and is now at a minimum of 12 to 13 Gray typically to the prescription. You can see the exponential growth of the referrals and the treatments for acoustic neuromas with stereotactic radiosurgery. There was a very rapid uptake of that technology, in particular once it was evident that the machine was working very well. The tumors were arresting in their growth, and side effects were, even with the higher doses, relatively minimal in comparison to the published acoustic neuroma data with microsurgery in those days. This is an overall series in Sheffield. You can see the yellow bars are the stereotactic radiosurgery for acoustic neuromas. And you can see that there has been in a pretty static use of that technology in Sheffield, about 250 patients a year. In the later years from 2017, this is reducing, and that is not due to the lack of referrals or a lack of interest from patients to undergo this treatment. It is due to a commissioning change with NHS England, which commissioned many other units to do the same work and deliver stereotactic radiosurgery for benign skull base lesions, acoustic neuroma being one of them, as well as meningiomas. So our outcome data is published from our own series here in Sheffield. We can show that growth control, that means arresting the tumor, can be achieved in 97%. The majority of the 3% patients will not require surgical intervention, even though the tumor is progressing. The reason for that statistically is because of their age and because of the slow progression of this tumor it never reached the level where it required an intervention. So failure rate is about 3%. Complications rates are very small in comparison. Under 1% permanent facial nerve injury can be observed. Trigeminal neuralgia or trigeminal deficits in about 1.5% permanent, and hearing preservation can be achieved in 75%. So in other words, 25% of patients will pull a short straw and their hearing will decline despite or because of gamma knife radiosurgery. That one will never know. Hearing preservation after radiosurgery in our series, Gardner-Robertson, grade 1-2, 76% preservation. Out of our cohort published at the time, 2 lost their hearing completely. Gardner-Robertson, grade 3-4, we had a hearing preservation of 75%. 11 in this cohort lost their hearing. And then the ones who have no hearing when they get referred or undergo radiation treatment, obviously, we do not restore lost hearing with gamma knife radiosurgery. What's important, and Professor Shakeel has already taken note of that in his excellent talk, the functional outcome after gamma knife radiosurgery versus microsurgical resection. There have been many published studies, including the Cambridge group, Professor Hardy, and then obviously we have renowned names like Sami with series of significant numbers of acoustic neuroma microsurgical resections. What's of note, even in the best hands, there's mortality. I note that this, I'm pleased to see it is below 1% now, but it is a major undertaking, and undoubtedly it is a very complex procedure with associated risks. There's a very big difference in facial nerve palsy that is highly significant after gamma knife radiosurgery. The risk of a facial palsy is significantly smaller than after microsurgical resection. And that is, I've just looked at Angelina Jolie there. Professor Shakeel is absolutely right. It is probably the most devastating injury an acoustic neuroma patient can suffer is a complete facial palsy. After radiosurgery, it is rare. I've seen it in my patients once, and sadly, that was a young lady, a very pretty young lady, who was there. That was even more devastating in those circumstances. But it does occur, so it is important to counsel patients of this, and it is important to reflect exactly what is the right thing to do. And it is, I agree, a multidisciplinary decision. It should be a multidisciplinary discussion. And the offer of what is done should be tailored carefully to the patient's needs and their wishes. And for that, it is important that the patients do know exactly what the risks and benefits are of either treatment modality, and expectance, that means doing nothing, is clearly an option for all of them. The impact on life is significant worse after microsurgical resection. The hospital stay is materially shorter after stereotactic radiosurgery, and the return to work is materially quicker after gamma knife radiosurgery than after microsurgical resection. That is well published and evidenced by the paper of Jean Régy in the Journal of Neurosurgery back in 2002. Now, stereotactic radiosurgery has gone through an evolution. In the early days, we started with patients referred suffering from neurofibromatosis type 2. This talk is not about neurofibromatosis type 2, because that I can talk half an hour just on that pathology and the use of best treatment options. We got referred patients after failed surgery, residual tumors, recurrences. It was an early period where people were looking, well, I don't really want to operate on this again, and let's see what gamma knife radiosurgery can achieve. And this is where the growth and the evolution of gamma knife radiosurgery took its shape. It became more apparent that hearing and facial function could be preserved better with gamma knife radiosurgery, and that gamma knife radiosurgery was not limited just to the fit individual who was able to undergo a long general anesthetic and a very invasive resection. The evidence over the years and decades, and in particular the widely published evidence, admitted that it is retrospective and selective case series which were published. And nevertheless, it was enough for NHS England to accept that this was a primary treatment modality, and hence NHS England commissioned stereotactic radiosurgery as a primary treatment option for acoustic neuromas back in 2013. Changes over the years, what we have noticed that the content of NF2 referrals reduced over the decades. The number of patients who had previous surgery reduced materially over the decades, and the volume of the tumors reduced materially over the decades. And that is due to the improved awareness by general practitioners, the better availability of high quality imaging, and the earlier diagnosis of these tumors. What was the status of stereotactic at the time of stereotactic radiosurgery? So patients with primary stereotactic radiosurgery, they come with a variety of symptoms. Many of them have hearing impairment, and some of them have facial palsies or trigeminal neuropathies. What was apparent in our cohort we got referred is that patients with previous surgery had a significantly higher incidence of being deaf, completely deaf, or having a facial palsy before stereotactic radiosurgery was delivered. And that is not surprising, because that is one of the associated risks of microsurgical resection, and that was in those days not that unusual. I remember one of my neurosurgical trainers, consultant neurosurgeon, who said that to me that a facial palsy is expected if you resect an acoustic neuroma completely, and that is not a complication. So this was the early attitude from which we have long come away from now. Previous surgery, what we noted in that cohort, there were 31 patients which we looked at in 2007 to 2008. 14 had a deliberate subtotal resection. Professor Shakeel has mentioned that already. Stereotactic radiosurgery was delivered between half a year to 3 years after surgical resection. 3 of them were not able to classify. 12 had intact facial nerve function, but 14 of the 31 patients had been told that their tumor had been resected within the last 3 to 20 years completely, and there were recurrences. So surgical resection, even when claimed to be total, does not mean that the tumor doesn't recur. Now, an interesting patient here, 45-year-old lady, she was investigated for right-sided deafness, and the ENT diagnosis and cause for that deafness was named as otosclerosis. She had an MRI scan and was found to have a left intracanalicular vestibular schwannoma. Now, what would you do? So it is of note, obviously, what Professor Shakeel already said, that the observation is an option and this is a route to take. The question is that really the best route to take? Now, in our experience and in Professor Regis's experience, who has published on that, is that the longer you observe these tumors, the more likely you are that you find that the patient you're observing is gradually losing their hearing, and that eventually they lose their hearing. And what they usually say, well, no, they kept watching me and until I was deaf in that ear. So that's obviously something what one needs to discuss with a patient, and that is always a risk one takes. The alternative is proactive management, and with that one takes the risks that the proactive management basically causes a hearing impairment or hearing loss. The hearing preservation with gamma knife radiosurgery in the Marseille group was 70%. In our own, it was 75 to 76. And when I, just reflecting on the data Professor Shakeel provided, then I think a proactive approach is not that an unreasonable proposal. Observation versus early gamma knife radiosurgery for vestibular schwannomas. What we usually advise is, if you have very good hearing, yes, you have something to lose, but if you preserve that hearing in 75%, and then you have long-term preservation, the tumor stops growing or regresses, then you have a chance to preserve that hearing for their lifetime. So it is something what should be considered with all patients. And at the end of the day, it is the patient who needs to make the decision, obviously having had the benefit of all the published evidence available to be considered and digested. So this is just an example of what we see in follow-up after gamma knife radiosurgery for vestibular schwannoma, treated in 1996. And you can see this going through the decade, nearly a decade, how it gradually regresses to just a little small area of scar tissue. This is obviously a very successful treatment when it works. And in the majority of patients, it does work. Another example of a regressing vestibular schwannoma. After 5-year follow-up, I have a shrinking tumor not seen coming back. So recurrences would be exceeding unusual. Is there a never? No, I don't think there is ever a never, but it is extremely unlikely. So lessons learned from acoustic neuroma radiosurgery: 75% hearing preservation, less than 1% facial nerve palsy rate, 97% avoid microsurgical resection. Early treatment for hearing preservation is and should be considered. Tumor relative limits are 3 to 3.5 centimeters, and combined strategies with subtotal resection, if necessary for very large lesions, is, I think, the standard of care nowadays to provide it to avoid the devastating cranial nerve deficits. Now, just very quick at the end, I skim through this. There's always this scaremongering about gamma knife radiosurgery causing malignancy. Anybody who uses ionizing radiation clearly needs to accept there is a theoretical risk of increasing a cancer and to potentially causing a transformation of a benign tumor into a malignant lesion. We have matched our patients against the UK Cancer Registry. It's the largest published study and probably the best world register of cancer taken here in the UK. We have over 110,000 patient years by the end of 2015. We are just working on our new data, which will be more than double than this. And we can show that we have not really an increased risk against the normal population risk of developing malignancies. We had 2 vestibular schwannoma malignancies in the group of nearly 10,000 acoustic neuromas. The SEER database published by Carlson at the time found that there is an estimate of 1 malignant nerve sheath tumor per 1,045 vestibular schwannomas without irradiation. That means there's a natural history of developing a malignant transformation. And the question really is, if the 2 lesions we have treated in our very large vestibular schwannoma cohort, if that is not just a background grade. So that's something to consider. Thanks to the team and thanks for listening.
Great, thanks, Matt. So that was a very comprehensive overview. And now I'm going to present something a little bit different. Really just an update of some of the work we're doing with AI and investigating different techniques to improve vestibular schwannoma care for the future. So artificial intelligence is obviously very trendy at the moment, and it describes the simulation of human intelligence processes by machines. And really, AI systems work by taking huge amounts of data, which we then label and structure, and then use a very high volume computing to make predictions about the future states. And there's lots of different types of AI. Many of you might use ChatGPT, for example, so natural language processing, and other forms of AI are in image analysis, for example, or in machine vision, so interpreting pictures and videos, for example. And driverless cars are a good example of how training AI algorithms work. So driverless cars use different algorithms to interpret the world around the car. And when you have to change your password for a website and they ask you to label what's a bridge and what's a pedestrian, you have been essentially training AI algorithms that then are now used to drive driverless cars. How do we apply this in medicine? So CogStack is essentially a program, an algorithm which can interrogate medical records, and using natural language processing can take unfiltered data. So all the medical records for a patient, for example, having vestibular schwannoma treatment, and it can look for associations in symptoms or in outcomes or complications, for example, that we might not otherwise pick up. So we've applied that in vestibular schwannoma management, and what you get back is quite unstructured. And the reason for that is because the data entry doesn't quite have the labeling that we need to be able to, for the algorithm to extract meaningful signal. So the way we structure the data entry is through process mapping. We do a Delphi consensus, so we ask experts on what they think is the ideal pathway of a vestibular schwannoma patient through the hospital. We then use that, we publish that, and then we'll use that as a basis for inputting data into the medical records, and then we can use that with natural language processing techniques to then extract signal to tell us, for example, why certain patients might get meningitis or CSF leaks, so brain fluid leaks, or facial palsies, which is we've been talked about a lot recently. But for that to be accurate, you need more data. So say that I developed this process and algorithm in Queen Square Hospital. Is that going to be applicable to Sheffield or other centres? And for the algorithms to be accurate and applicable to all patients, you need to collaborate. So we're setting this up for a study looking at why we get brain fluid leaks after vestibular schwannoma surgery. We published a meta-analysis demonstrating there are many different ways to do a vestibular schwannoma operation and to make a repair of the dura to prevent CSF leaks. And we capture that spectrum of variability with a national audit, and then we can use that data with our algorithms to try and pick out the signals that can tell us how to prevent that complication of surgery. Another example is operative workflow analysis. So this is using AI algorithms, training them on labeled data from operative videos, and then generating an algorithm that can interpret an operative video, and with that interpretation, then tell us in surgery what part of the operation may or may not have led to complication, or we could do a bit better, or could be a bit shorter, for example. The way we do this is we have to codify an operation. So same sort of principle, we have to structure an operation, and we do this with a Delphi consensus. So with the British Skull-Base Society, we send out a survey to all the expert vestibular schwannoma surgeons in the UK, and then we come back with a consensus of breaking down an operation into all its constituent steps and phases. And then we label the operative video. So this is very labor intensive. So our surgical trainees will be going through all our operative videos and labeling what the instruments are, labeling the anatomical structures like the facial nerve, for example. And the output, which we're just publishing, and I won't show you the video, just where this will be online, but the early data from this is very exciting. So we can now play videos of operations, and the algorithm will tell us what phase the operation it thinks we're in. It will be able to predict that we should be on the next phase of the operation. It can predict what instruments are coming next. And with that information, extending that over different hospitals and different centers, we can then train surgeons. So we can say that for trainees, these are the parts of the operation which are important. We can also correlate this with outcomes. So that phase, for example, was wrong, or was in the wrong order, or done in the wrong way, and therefore that might be associated with a certain complication. In this case, we can again use the example of brain fluid leaks. And then in radiosurgery, AI, again, in this context, there are three main strands of our research. So again, we want to really get better at predicting which patients are going to respond to the treatment. So you can have radiosurgery for a fast-growing tumor in a young patient, and the tumor can still grow despite the treatment, and then the patient will have to get rescue surgery. So could we have improved our decision-making at the beginning of that process and opted for surgery up front? Also, the prediction of gamma knife-related complications, so things like radiation edema, balance problems that can happen after radiation treatments. Can we predict which patients are more or less likely to get those complications? And the three strands: image segmentation, radiomics, and predictive modeling. So image segmentation, this is work that Jonathan Shapee did when he was with us at Queen's Square a few years ago. So contouring the shape of a tumor and developing algorithms that are now published and open access to be able to give us a volume of the tumor, and also these now help us in planning for radiosurgery. What's difficult about this is contouring complex shapes. So although a primary vestibular schwannoma is a simple task now for an algorithm to understand, the post-operative residuals, for example, are much more complex, and the current work we're focused on is understanding atypical shapes and also segmentations of post-operative scans. This work we can then correlate, as I say, with, for example, the dose that you use, the planning, and also potential complications. Radiomics is then an extra layer on top of that. So in addition to just the contours and the volume, this is now taking all the additional information that we have. So the shape of the tumor, the texture, maybe the signal intensity of the tumor, things that you might identify could be correlated, for example, with treatment failure, but we're uncertain. But an algorithm can pick up quite easily with high volumes of data, will then be able to tell us maybe a tumor, for example, that's more heterogeneous, that has brighter signal, more likely to fail treatment, for example. And then the last part is really adding all that information together into predictive and prescriptive modeling. So not just the volume, not just the imaging features and the radiomics, but then bringing that all together with the clinical data, with the histopathology, and generating prediction models, and also tools, so decision-making tools that we can use in our multidisciplinary meetings and also in clinic to help improve our decision-making and make sure we're making the right selections for further treatment. So these are the questions that we might be able to answer with these techniques. So for example, this patient has a tumor with features suggesting a 60% of control of the gamma knife, maybe surgery is better for him, or this model predicts a high risk of radiation edema after treating with a specific dose, and maybe we should prescribe a lower dose. These are the kind of questions that we may be able to ask and answer with these techniques. So this is our research lab and our plan in terms of developing those techniques within radiosurgery. And I know we're overrunning a little bit, so lot of questions in the comments, which we'll address with the panel. We'll move on to our last speaker, who's James Gibbons. He is a member of BANA, the British Acoustic Neuroma Association. He's going to give us an overview of the association and how you can get involved.
Hello everyone. Yes, my name's James. As I said, I am currently a trustee. I'm actually vice chairman of the British Acoustic Neuroma Association. A bit of my background: I am an acoustic neuroma patient. I was diagnosed with an acoustic neuroma in 2016 when at the time I was living in Australia. I was told surgery was the only option. It was a big acoustic neuroma, 3 centimeters was mentioned, and 2 months later I had the operation. This in trying to come to terms with having the acoustic neuroma, massive life changes. 2 things I always found was it's hard to explain some of the issues of living with an acoustic neuroma. Single-sided deafness, oh well, the other one works okay, as a common answer. It's a malignant, it's a benign tumor, oh well, that's good, isn't it? So it is very hard to get a lot of understanding as a patient in the world, with friends, family, etc. So at some point I made the decision to return to the UK, and that's when I discovered BANA, the British Acoustic Neuroma Association. I did some Googling, I discovered BANA, I went to a meeting, and before I knew it, I was working for them part-time, working for them as a volunteer in the office doing their finance work. So that's how I came to be introduced with BANA. The great thing that I feel as a patient, maybe the main thing that I've found it useful for, is that it's good to be able to talk and with people who understand the problems, people who have gone through the same situation as myself. So what does BANA do? BANA's main aim is offering support and information for people affected by acoustic neuroma. So there is a website with a lot of resources for people at diagnosis stage. It's certainly something I would have liked to have had access to when I was diagnosed, right through to the treatments that are available, and then living afterwards, after any treatment, and ongoing for those that are on watch and wait. The website for anyone interested is www.bana-uk.com, and you'll find on there all the information I'm talking about. Basically, what we do offer, so we have support groups. Some are face-to-face, and some are now virtual. In some cases, they are regional, so the face-to-face tend to be people from a certain area, but some of the virtual ones will be aimed at those with particular problems. Facial palsy is one, tinnitus groups are another, and all sorts of things. We have an annual conference which has been very well attended. I've been to a few of them now. They're always very good days, a few presentations, mainly from the medical field, but very often members will talk about their AN journey, and yeah, it is a very useful thing. We have a medical advisory panel, so members can send in their questions, and we can forward them on to the relevant people. We have a group of people in the medical profession in different areas of expertise who will answer questions in that way. We have a listening ear service where members can talk to other members, say people who understand what they're talking about from experience. The office, we have an office which is based in Chesterfield, which is 3 staff, 1 full-time who is the CEO, and also 2 part-time staff. Funding is obviously an issue. Fundraising is a big part of the office staff's duties. Funds are raised through membership. We currently have around 600 paying members. Some have been members for long term. Very often people join when they are diagnosed and decide the first year is enough for what they want. Fundraising is a big part. We have members, family members, etc., who have done things like marathons, long distance walks, and a whole host of things to raise funds. And also we're applying for grants, and if you visit the website, you have every chance to donate to BANA if you so desire. I think that's about. Yes, let's say BANA is always keen to connect with the medical profession. So if anyone is interested in connecting with BANA, so if you go to the website, there's a contact us with email addresses, etc. on there.
Great, thank you. Thanks, James. So we'll bring all the panel now onto the stage, and in the last 10 minutes or so, we'll go through some of the questions from the audience. And the first question is, in patients with bilateral vestibular schwannomas, how does your MDT approach balance, I presume, hearing preservation and long-term tumor control? So, Shak, do you want to start us off with that one?
Yeah, I mean, so we're talking much of what we've been discussing as related to unilateral sporadic vestibular schwannomas. I think Matt's talk was about that, and mine certainly was. Of course, Matt touched on the role of radiosurgery in NF2. So as far as the UK is concerned, the management of NF2 is formally commissioned in 4 centres, one in London, one in Oxford, one in Cambridge, and one in Manchester. And the reason that's evolved to that situation is because precisely of the complexity of managing these individuals who have not just necessarily bilateral vestibular schwannomas at one end of the spectrum, which might be what we call a mild phenotype, through to a large tumour load throughout the head and the spine, as well as other disabilities affecting vision and so on. And it's really complex in terms of making the correct decisions with the patient, and the multidisciplinary input relates to physicians and surgeons and oncologists and radiation oncologists for that very reason. And so the management of NF2 has evolved. In fact, Matt touched on this as well. So increasingly, we've moved away from intervention unless there is a compelling reason to remove a tumor surgically because of its mass effect, to looking at alternative management options, including the role of radiosurgery, although that's variable, but also the role of drugs such as bevacizumab to try and control the tumor load, and increasingly looking at preserving the functional hearing of the patient for as long as possible. Because at the end of the day, if you have an individual with a large tumor load with large vestibular schwannomas, there isn't a surgical, certainly that's going to be curative, and in fact, surgery may well cause more harm, has done, than in individuals, sadly. But that's where the team effort comes in.
Okay, the next question is from Jenny. How do you approach shared decision-making in borderline cases? So when patients' priorities, e.g. preserving a non-dominant ear's hearing, are not strictly clinical. Matt, do you want to?
Well, I mean, that is, at the end of the day, a growing acoustic neuroma poses a risk to the patient in the long term and will cause eventually untreated a demise. So, you have, once a tumor is growing, you need to think about the strategy. And it doesn't matter if that is, the hearing preservation then steps into the background, really, if it starts compressing the brainstem, starts to cause hydrocephalus, etc. So there comes a point where choice is very limited, and you need to see what is the best combination of treatments, or what is the best treatment for that patient. And it depends on age, it depends on occupation, it depends on outlook on life, life expectancy, on so many other factors. And the importance is that it is carefully tailored to that individual needs.
Okay, now the next question is from Rollo. The question is, do patients' response after interventions contradict their decision to go with the consultant's opinion or guidance? Is there any data on this? Shaq, that ties in with your talk, I think?
Yeah, I'm not sure I fully understand the question. So the patient's response after intervention contradict their decision to go with the... Yeah, I don't quite fully understand the question.
I suppose it's how often do we find that actually a clinician has recommended a certain intervention, but actually it turns out that was wrong. So maybe well, I guess an example might be a patient who's had Gamma knife and then is a treatment failure. But I suppose there is data on that. I mean, there are many published series about treatments and their outcomes and treatment failures and complications, but it's hard to say whether it's the original treatment decision was right or wrong in the first place.
Okay. Yeah, well, let's just have a think about that. So if the consensus from the MDT is that the patient has a small growing tumor and the time has come to treat it with Gamma knife, for example, and the Gamma knife fails to control the tumor, and there's only a few percentage risk of that in reality in the correctly selected patients. That's our experience at Queen Square. That's certainly the experience in Sheffield, as we've heard. But if you're one of the few percent where it fails to control the tumor and you need subsequent intervention, i.e. surgery, then that is a risk that the patient would have been counseled about, hopefully in great detail, prior to reaching that decision. If a patient is advised to have a certain intervention and elects to, for example, have surgery instead of Gamma knife, and the patient ends up with a facial palsy, then that is clearly regrettable. But what I showed was that study from Norway showed that the decision the patient makes in the vast majority of instances, the vast majority, will be based on what the team says to them in that clinic room in terms of the recommendation for management. And that's where I have a problem, in the sense that what are the team basing their decisions on in terms of data, and is it just their own experience, and so on and so forth. Yeah,
I suppose what we haven't really touched on so much is the so I think Matt was presenting data comparing surgery versus radiosurgery for primary tumor, but I think what has changed in those surgical series compared to how surgeons practice now is that we can now use Gamma knife radiosurgery for tumor residuals. So actually the surgical outcomes for a primary tumor that's operated on are different now, because surgeons' behavior will have changed, because we can leave more tumor behind, and that means that in reality facial palsy rates should be very low for surgery and for radiosurgery in the right patients.
Well, I can say with it. So I've looked at the first 150 surgeries, and then I've got a prospective record of the last 150 odd surgeries that I've done. And in the latter cohort, a substantial proportion of them will be near total or planned subtotal, and the facial palsy rate is 1 or 2%. It's a very, very small number, but that is with a view to then proceeding with Gamma knife treatment, because Gamma knife is what we use at Queen Square, or whatever form of stereotactic radiosurgery you want to use, if the residual tumor is of a size where we think it should be treated from the outset, or whether if it shows signs of growth. So what we're saying to patients now is that we're going to preserve life, limb, voice, swallowing, facial function, and if needed, leave a small residuum of tumor, which we can then treat with Gamma knife. So you've got bimodal treatment options here. And if it was me, I can tell you, I'll be very clear. If it turns out that I've got a 2.5 centimeter vestibular schwannoma, then I would have it resected, but I would instruct the surgeons that you must not cause a facial palsy, even if it means leaving some tumor, and then I'd go to Matt and have it irradiated. That's what I would do.
Yeah. Okay.
But you select your surgeon very carefully, and you have the knowledge who to select. Now, the problem is that the general public doesn't have that knowledge and doesn't have the ability to select. And that's one of the things what I've noticed in my decades of practicing, that the patients, surgeons quote the best published literature, and I have heard a surgeon quoting Zami's outcome results, knowing that he himself has never looked at his outcome himself. So sadly, not everybody knows their outcome results. You obviously do, but not everybody does. Not everybody does publish their results. So the general public has very little chance to pick themselves put themselves into the right clinics and ask for the right referrals.
Let me comment on that. So you're absolutely right, Matt. And this is a comment for individuals watching this discussion, but particularly for James as well and for BANA. If you are sitting in front of a surgeon or a multidisciplinary team, you've got to ask them what their outcomes are in terms of the numbers that they've treated, whether it's gamma knife, whether it's surgery, whether it's a combination thereof. And if they do hearing preservation surgery, what are the outcomes? And it's got to be their outcomes. And by definition, that means that they are auditing their data. If they don't do that, I would go somewhere else.
I agree.
I would add an extra point to that, that now in the NHS, every surgeon will be sent their data for facial palsy rates and CSF leak rates in the model hospital data for vestibular schwannoma resection. So that's being rolled out, and it does mean as a patient, you should be able to go to any clinic with any surgeon and ask them what their data is for the last few years, and that they will have access to that.
Yeah.
So
just one quick comment.
No,
I personally like patients to be counseled by a microsurgeon in a separate clinic. I don't like to be in the same room at the same time, because exactly to avoid that influence and that biasing a discussion and influencing it one way or the other. You're absolutely right. What you said, the publication and the references you made are brilliant, because there is deep down, you can't help yourself. There will be always an attitude and probably some perception and some view you can't hide. So it is, I think, very important that you have an independent microsurgical counseling to a radiosurgical or radiotherapy counseling, and then to mull this over and make your own decision. And I think the important bit for the patient is to buy into that decision and to stick with it.
Yeah, I mean, and this is the crux of what I was saying about the emotional and other investments. Emotional investments are understandable. We're only human after all, but there are two types of understanding. One is belief and one is faith. And belief is based on, it's an intellectual process based on facts. Faith is very variable. And the problem is that there are teams or individuals that undoubtedly will give advice based on emotional investments, which are understandable, but what are not acceptable from my perspective are other types of investments in the decision-making process. And the beauty of the National Health Service in the UK is that our decision-making on a particular day, on a particular patient, in a particular clinic is not influenced by financial aspects. The beauty is I get paid for not operating on patients.
Okay, so we've got a few more questions. We'll just try and run through them. Sarah's asking, is it possible my acoustic neuroma could be different, could be a meningioma, as they present the same? I'll I'll tackle that quickly. Usually, it's pretty clear from the imaging features which is which. Occasionally, you might find that there is uncertainty, but then actually, as you say, the behavior is the same and the treatments paradigms are similar, so surgery or radiosurgery or observation. So it's possible, but usually you can tell the difference. Bilal's asked, do we take serviceable hearing as one of the indicators to decide what modality to use? And if so, what decibel hearing frequencies guide this decision? Thanks. Probably one for you, Shak.
Yeah, it's as I indicated in one of my slides, the decision making relates on the tumor size, the patient, their age, their general health, and their hearing. I've talked enough about who's managing it. So let's talk about the hearing. And this is critically important. We actually hear with our brains, not our ears. And the hearing centers in the brain are finely tuned to what we call binaural hearing input from both ears. So when the decision making is happening, the hearing in the non-tumor ear is also vitally important, not just the tumor ear. But what we define serviceable hearing as, well, let's put it this way. If you have age-related hearing loss and your average hearing level is up to even 70 decibels, then a good quality, well-optimized hearing aid will help you. Now, the slight difference with if you've got a vestibular schwannoma is that there can be a disproportionate difference between the quantity of hearing and the quality of hearing. And that's where the speech understanding comes in. And so you've got to look at not just the decibels, but the speech discrimination score. And so really, in reality, serviceable hearing is 50 decibels or better and 50% score on the speech tests, because that is still hearing that I would want to try and preserve if possible. Once you get beyond that, the particularly if speech discrimination is poor, then that becomes less serviceable hearing. So for me, 50-50, that's class B hearing. Class C possibly as well is what we would call serviceable hearing.
So we've got 3 minutes left. We've got a hard stop in 3 minutes time. So I've got a quick question. How do you think AI could help doctors decide which vestibular schwannoma patients need treatment right away and which ones can be safely monitored over time? Well, a lot of the work with the image segmentation, the radiomics, and the predictive modeling can certainly help us. So looking at the tumor and its appearance on the first scan and seeing if there are features you can pick up that might predict it's one that's going to grow rapidly or not grow at all. We always have time, which is why we usually do a repeat scan before making a treatment decision. And also there's ongoing research. So what Matt was alluding to are studies that are coming online looking at whether we should be doing upfront treatment for hearing preservation for small vestibular schwannomas with gamma knife versus waiting and treating after demonstration of growth. And then maybe a quick answer to this question, is there any benefit to starting vestibular therapy before surgical intervention to support balance recovery? Again, Shak, maybe.
Yeah, I don't think it does any harm. There is a vogue in some centers to actually purposely destroy the balance function in the ear that's got the tumor using an injection of an antibiotic called gentamicin through the eardrum, so that the balance recalibration happens even before the surgery. And we can debate that. Because we're short of time, there are two that stand out for me. There's a question from Giannis Socrates about whether there's a correlation between tumor growth and hearing deterioration, and there isn't. So you can have hearing deterioration and you have your scan and the tumor's not grown. Conversely, the tumor can grow and the hearing is not necessarily any worse. And then finally, Cara McCladdery has asked about the role of cross-aiding. That's contralateral routing of signal aiding. I think that if you've got good hearing or normal hearing in one ear and your tumor ear hearing is poor such that the hearing aid can't help it, then I think cross-aiding is a very, very good way of at least trying to help with that. And if that works, then we do have a range of bone conduction implants that can be put in place above and behind the tumor ear, most of which are MR compatible, to help with the to help mitigate the non-hearing side, if you like. So I think that is certainly worth exploring, just to pick up on those two hearing issues.
Thanks, Shaq. So I think we have to wrap up. So thanks to the panel. Thanks, everyone. James, Matt, and Shaq. It's been a fantastic session, and
Thank you.
we'll be coming back with more very soon. So
Thank you.
thanks, everybody.
Great to see you again, Matt.
Bye.
Yeah,
Nice to
thanks,
see you.
James.
Bye. Thanks.
Yeah.
Thanks a lot.